participate in a lot of back care. You know, there's, and maybe you don't know this, but there's a lot of maybe some animosity even from healthcare providers to back patients. The term malingering comes in a lot. Have you ever heard that term? Malingering kind of says, oh my back, I really can't do that. I can't go to work today, right? And now you're probably starting to see that type of personality switching in. And malingering is basically the production of fake symptoms to kind of get you out of something. I'm thinking of a movie called Ferris Bueller's Day Off, and if you've never seen it, it's extremely expensive to buy on Amazon, but you should go get it. But he talks about how you fool your parents by faking a cough or sneeze and then licking your palms to indicate that you have clammy palms, and that's a really good selling point to faking sick. That's malingering right there, right? And so a person will come in and they'll say, yeah, I can't go back to work. You have to understand, I have back pain. And you know, back pain's different. Like if they sprain their ankle, you see that big swelling. If they tear their ACL, you see that big swelling. If their shoulder hurts, man, you can almost grab that shoulder in passive range and really detect that there is a capsular pattern. And I'm bringing that term in early because we talked about it yesterday. Or the elbow even. If you jam a finger, like you see that swelling, like it's really easy to produce some evidence to that. The back is just not always that way. We will look at one very specific scenario that's incredibly evidential of back pain this morning. But one of the things that, again, it just comes up. And so for me as a student, I just left and I thought, I just don't want to do backs. Backs come from, or spine issues come from car wrecks too. You know, we have a rule in our pro bono clinic that we just will not work with a patient who is in any type of litigation. So we've turned away a ton of patients who had car accidents who, in most cases, would be really good patients for you to see, but we don't want anything to do with that because we just don't want the drama that really follows that, right? And that's just as truthful as I can be about it. But again, there are those true back patients. In fact, the majority of days missed from work come from low back pain. And if you have not experienced low back pain yet in your life, just wait, it's coming. You're going to have you're going to have your own experience with that. I'm going to hope and pray that that's not a bad experience. I really didn't have any issues with my own back up until I started into my third decade in life, and that's where some things kind of started cropping up. Experienced an SI joint dysfunction, which we'll look at very specifically on Monday. I know Deanna talked about that yesterday. And then long before I knew it, the middle of my third decade, I had a herniated disc. And so again, we kind of talked about that last semester in Ther Ex I, where we compared it to the jelly donut, right? And we're going to get into that this morning as well. But one of the things that we need to do is we need to educate our patients on what to do. And one of the first things you have to be able to do very effectively is teach them some bed mobility. So right out there in that first area under your notes, it talks about patient education. I want you to really kind of think about what you're going to do here. Number one, you're going to address bed mobility goals, right? So you could even write that down, like when you see bed mobility goals or bed mobility as a goal, this is for the spine an incredible intervention to meet that goal. And just like I've told you before, I tell my kids over and over and over and over, you're going to tell your kids or your patients over and over and over. This is one that you reiterate, because they'll kind of want to just operate without it, because it does take a little bit of time and intention to do. But the very first thing you want to teach is a log roll technique, right? And there's a couple of things to say about the log roll. Number one, the log roll is either an independent maneuver that they need to learn, or it's a dependent maneuver that you do to a patient. Well, for this one, it's an independent maneuver. They want to be able to do this. And so there's just a couple of steps from that. Now, most of the common presentations are from supine, or from the supine posture. So they're laying on their back. If they're laying on their side, they're already one step towards it, right? But they need a safe transition from there to standing is basically what we're going to do here. And so to teach this, the first thing we're going to need to do is from supine is to get them to side lying, all right? And then when they side lie, what they will do then is they will flex hips and knees. So what we'll do is if they're in a bed, right, we'll teach them to come roll towards us. And this is the log roll. Now to do that, they need to learn how to initiate the movement here. And what I like to do is I like to have them reach. And what that does is that gets this whole trunk maneuver to occur. But they have to kind of tighten up right here to do it safely. Otherwise, they're going to rotate and possibly irritate whatever spinal pathology is going on. So I just teach them to reach over. Don't grab, but just reach and use these muscles. And let's just kind of come over. There you go right there. Now, this maneuver requires momentum. All right, so if you read about this, if you see this presented in YouTube skills or anything like that, it requires momentum. And so please keep that in mind, that as you teach it, they need that momentum. That's part of it. It's a fast movement, or at least by virtue of control, it's pretty fast. And so what they're going to do is, in one sequence, they're going to get their hips and they're going to flex where their knees come to the end of the table here. And at the same time, they're going to use their downside arm to push and their upside arm, which is his left, to push as well. And he's going to sequence this to where he comes to a full sitting position, right? Now, that was a pretty slow maneuver, and that's okay. And it may take that because they may have such instability or pain here in this area that they're not interested in doing it that fast. But we look at this too from the neck. You know, you think about if you do have a neck issue, and many of us have had those. We've woken up with this thing called a crick, right? And we talked about that before. We're going to talk about that again later this morning. That crick issue, right? So they can stabilize around that neck kind of isometrically and do this same log roll maneuver, and keep it safe. But it's about getting them out of bed. So bed mobility is getting them out of bed, right? And that's a pretty important part of what we're going to do. So let's try that just a little bit quicker, Noah. Go ahead and come back down and go all the way into supine, right? And so the rolling initially can be pretty slow, right? They get to here, but it's when they take their knees and surpass that bed threshold right there, that all should kind of come into one quick movement. All right, so let's try that one more time. Very good. And so one of the things, even like today, I know it kind of sounds weird, but one of the things that I do almost every morning is as I'm getting out of bed, is I think, okay, I'm going to log roll here, and I've just kind of taught myself to do it because I don't want to risk, what we'll learn later is probably one of the big causes of back injury, and that's a flexion action, right? We flex up, and it just over sequences these muscles right here. And so when I do that, what I do is I just come to here, and I just push all together, right? And you see, as my knees surpass the threshold, that's when that action will happen, right? And so that's just kind of the sequence you want to be able to teach. So the first thing we're going to do this morning is teach the log roll. Next on the list is identifying safe and pain-free postures. This will make more sense later when we talk about what a flexion bias, extension bias, and weight-bearing bias is. But just by virtue of those words, what does bias mean?
Something you prefer.
It's the position, yeah, so it's a posture you prefer, right? And listen, and I'm going to reiterate this later, they will tell you what to do for them. Your back patients will tell you what to do for them. Because they'll walk in and they will say, I can't stand anymore, I'm sorry. I've got to come, I got to sit. Well, that just tells us as therapists they can't bear weight, right? And so you hear that and you say, okay, they need a non-weight bearing intervention set. Or they'll come in and they'll say, listen, do you mind while we do this if I stand, right? And if they're standing, they're more in an extension. And that's probably telling you they need extension set interventions. Or they'll say, I just need I either need to kind of lean, or if I could sit, that would be okay. But I mean, I can stand, and it doesn't hurt to stand, but I just have to kind of lean forward. And they indicate that there's a more flexion to that. So you help them understand that by saying, listen, what positions do you find discomforting or causing pain? They'll tell you, listen, if I sit very long, it hurts bad. Well, that indicates the extension, right? Do you see that? And then they say, if I have to stand straight like this, or if I lean back, oh man, I feel it going down my leg. It goes all the way down into my foot. If I lean back at all, right? That's telling you extension hurts. So they're probably flexing. Or if they just come in and they say, listen, it's killing me to stand. Like I gotta sit down, right? And you're gonna find those because of weight bearing. And we'll kind of make that more clear, especially how the disc is involved, or possibly even the SI joint is involved. So consider those as your treatment methods. And so you tell them, okay, we're going to do more of this, because especially in that early acute phase, we want to reduce those pain-provoking opportunities, and so that's patient education. Number 3, or C, is identify the neutral spine, right? So we did that before. Now, I want to tell you something. You were all fairly within the complexity of that in the Ther Ex I component. But remind me, how do we identify a neutral spine? What did we do in Ther Ex I that helped us to identify a neutral spine? Posture starts where?
At the feet.
In Ther Ex I, I said posture starts at the pelvis. And so to identify a neutral spine, and I'm specific to the lumbar spine here, how did we identify a neutral spine? We had to do a pelvic tilt. And so here in my neutral spine, there's my posterior pelvic tilt. There's my anterior pelvic tilt. Anterior pelvic tilt increases lumbar lordosis. A posterior pelvic tilt reduces lumbar lordosis. We want it to be dead set in the middle, right? And neutral. So we teach them, okay, when you sit, don't sit super slouched, right? Like this. And don't really push out too much. Although we're going to teach you some techniques to help with that. And that may help to extend that a little bit more. And we'll show you a scenario where that happens. But you got to identify that neutral spine. And that's a lot of you saying, okay, can you show me? Oh, yes, you can. Okay, good, you got it. So identify that neutral spine. What's letter D?
Lifting technique.
Yes. So to protect the low back, we want to probably encourage them not to lift by doing this. Now, I want to be really clear. They will eventually graduate out of this to where they can return to this style of lifting. What's this lifting style called? Stoop lifting, right? But while they're injured, we want them to do a lifting style where they protect the low back and come down. Now, their range of motion will dictate what they can and cannot do as far as this is concerned. For instance, if I see this cooler here and I need to pick it up and move it, because their life is going to go on, so they need to be able to do things. The thing is your job is to teach them how to do it safely, and I approach this cooler, my inclination is to bend over and grab it in the stoop lift, right? Well, that's not what we want them to do. In fact, what we want them to do is we want them to see that, approach it, possibly put it between their legs, right? Because where does my center of mass now land is in the middle of that object as I lower it, and then they're going to squat down and pick it up. Now, if that's too big, then they just need to know that that's just not what they're going to do, right? But that is what I have to do. So I have to teach to keep that neutral spine into a squat technique. Their squat may dictate how much they can lift. Like, they may not have a great squatting technique anyways. Like, you look at mine and you're like, gosh, that's ugly, Kendall. And I'm like, yeah, I agree. Okay? So that's what we're going to teach on the lift, is a squat technique. And then finally, we look at bracing and splinting. So there's a lot of variety of braces out there. You've probably seen the one, and we don't have one in our supply, but the Velcro that comes around, it's just kind of a common back brace. This we're going to talk more about on Monday. This is called a chair back brace. And as it goes on, it's used for post-surgical like fusions and laminectomies, and I know that that's some new words. We'll talk about those on Monday. But it kind of comes around, and then it's also commonly known as a corset. And so if you've ever heard of a corset, kind of a binding, and they go on very, very tight, right? But you can see kind of, if this was on and strapped down, what it would do there, right? It would keep me from doing a lot of trunk flexion, right? I have to hip hinge to move on that. I also am required to squat, but I only have so much. And that's why these are so effective. So you would want to educate on what to do with that. We also have, for the cervical spine, this is a soft collar, right? So may I? So there you go. Just something to kind of help to reduce the movement, but also it will kind of pad, and it does allow some, right? And then you have the more rigid Philadelphia collar. A lot of times you see these more in with emergency medical services, right? Like somebody had a car accident. You'll also see these put on patients after cervical surgeries. So, well, you've got a hood on. All right, Dakota's our mate. Go ahead and stand for me. Right, and so this is just another type of collar that you need to be aware of. That's a Philadelphia collar. That's a soft collar. One of the things too that comes up is this is a really, like we saw that right over there, and we'll see those chairback collar or those chairback corsets when a person has a disc fusion or a lumbar fusion. For a cervical fusion, this is what you're going to see. And what you're going to find out on Monday is that cervical fusions typically occur from an anterior approach. They go through, they move the trachea, and they do all of the fusion work on the front side because there's just not a lot back there to really protect it. But on a lumbar fusion, they go in from the back most commonly. I know there's now a lateral approach that they use for that as well. But there's your collar. And so it's just kind of important to remember, you know, what are the parameters of their condition that really need those, right? Early on, you would want them to kind of remain in those almost full time, taking them off mainly for bathing, but definitely they're probably even sleeping in them. So keep that in mind. But a lot of times it just depends on what the condition is. If they just have a strain in their neck, you know, we may take that off to sleep in, and it may not be on there very long. But if they had a cervical fusion, that dude's gonna be on there for a while, right? So we'll look at it that way. All right, so first thing, grab you a partner. Let's teach them how to log roll. Make sure you know how to log roll, and look for those indicating keywords